Thanks everyone for the invitation. Just check that everyone can see my slides okay? Yeah, okay, excellent. I'm David, I'm the nurse practitioner at Western Sydney Local Health District. I'm a drive around Parkinson's nurse. That's as basically as I can put my job. That's where I'm primarily based. But in private practice, I focus more on patients with deep brain stimulation because it is a sort of specialty area where there's different skill sets that you need to do those type of things. But so that's my two jobs. One's my day job, and I call the other one a moonlighting job. If usually I do these sessions one-on-one with patients, I can recognize some of the names here that I might have done these sessions with. But what I'll try to do is I'll try and consolidate some of the FAQs, the frequently asked questions that people send to me, and I will try and answer them as we go, okay? Some of the things that we will go through today is, the most basic stuff is, can we better optimize what we are currently on? What some of the options we have available? A lot of questions people ask me, am I too old for it? Or how long does it last? Can I afford it? And these are the things we'll go through slide to slide as we explore through the topic of DBS. And then after that, I'll answer any questions that people might have if it's not already answered within the presentation. So I just want to clarify one thing with a lot of patients is that people think that advanced treatments are treatments for advanced Parkinson's disease. So you have to wait till you're in an advanced stage in your Parkinson's disease before you introduce these treatments. But in actual fact, any of these treatments can be initiated at any time point of your disease process. But the main question to ask is it the right time? And is it appropriate to introduce it at that time point of your disease progression? So when you think about that, you have to think about your own journey, your own lifestyle, and whether it's worth it at that particular time point. So from this point forward, in order to sort of alleviate that confusion, people have started calling these advanced treatments device-assisted therapies. So they're just a form of therapy, but using different devices to deliver that for you. So the first question I often ask people, as we go through their history one-on-one, is, when what they're on, can the medication therapy be optimized further? So if you look at this is a real sort of typical schedule that some people might be on. So you might have some immediate release medications throughout the day as your primary therapy. You might have a slow release medication at nighttime called Cinemet slow release. And then you might have something called an MAOB inhibitor, like an enzyme inhibitor, such as Azilect. You might have some dopamine agonists like Cifrol, and then you might have some rescue medications such as Matapara Rapids. So this is a real typical type of schedule. That's, when I look at this, I would think, oh, that's pretty maxed out here. So, but when you think about that and look at your own schedules, how far are you from this? So if you're only taking medications once or twice a day, then maybe there's room to move with your oral medicine. But if for some reason that you're already like taking something like this or even a bit more than this, then you're probably looking into the device-assisted therapy realm. So before we dive into, going ahead and probing your brain with and drilling your holes and whatnot, I think one of the key things we need to think about is what are my other options? You have to know your options before you dive into something so invasive. So there are patches for your Parkinson's disease that some people might be on. So these are what we call reticotine patches or Nupro patches. And how it works is it's a sticker that you put onto your arm or some part of your body, and you peel it off and replace it every 24 hours. So it's not invasive. It's pretty easy to start and stop. And obviously you have to build up to your doses. So this is something that you might be able to speak to your neurologist or your specialist about starting, if that would fit in with your lifestyle. So that's one option there. The second option is what we call apomorphine injections. And these type of injections are what we call rescue medications. So they work within 5 to 10 minutes. And I always describe this as sort of like a EpiPen for your Parkinson's disease. So when you get in situations where you're stuck in a shopping center and you can't get back to your car and your 3-hourly time for your shopping mall is almost up, then and you can't get back to your car, these are the perfect situations to use these. So you would just inject yourself into any fatty tissue, usually around your belly, and then you get back into your good state within 5 to 10 minutes. So the needle is as small as we can get it. So for those who are needle phobic or scared of injecting yourself, it's pretty much the smallest one we can get you. So, and people, most of the time when they do it the first time, they feel like it's just like a mosquito bite. So that's something that you can consider as well. And this is called apomorphine injections, okay? Now, along the same lines as apomorphine injections, apomorphine also comes in an infusion form. So what this does is you have to put a little butterfly or a cannula into your fatty tissue, into your belly, and then it runs medications into you at a really, really low rate so that it gives you a bit more of a background level. So although it's the same drug, the concept of how it's used or what it's used for is slightly different. So when you use these infusion pumps, you will most likely reduce the amount of oral medicine you take. So say if you're taking medicine every 3 hourly, it might be able to stretch your oral medication out to 6 hourly, for example. So, but obviously that titration process would be negotiated with your specialist as well. This is minimally invasive. There's no commitment to it. So if you don't like using it, you can always just go back to your oral therapy reasonably easily. Now, this looks bad, but please bear with me. This is called duodopa. Duodopa is one of the best medicine we have on market at the moment. So it is just basically your cinnamon or Kinson made into a gel form. And how it works is actually delivers through a pump. So the pump is attached to a tube which goes into your stomach. And then within the stomach, there's a thinner tube that threads all the way into your small intestines. Now, the good thing about it is because small intestines is where your medicine is absorbed. So when you use this, we can actually deliver the medicine straight to the site of absorption rather than wait for a tablet to sit in your stomach and then wait for it to get moved down to your small intestines to get absorbed. So the absorption is a lot more reliable. And because it's gel form, we can fine tune the medicine down to 0.1 of a mil. So if you imagine yourself trying to peel off a quarter of a tablet to 1/8 of a tablet to 1/16 of a tablet, it'll probably crumble by that stage. But because it's in a gel form, we can fine tune the medicine down to 0.1 of a mil. So it's very, very accurate in terms of adjusting for your Parkinson's symptoms. The good thing about this medication is also that you can monotherapy on it. So it's a fancy word for we can get rid of all your oral medicine and just use the pump. So that's how powerful it is. So moving on to deep brain stimulation, I think one of the first things we need to talk about is that deep brain stimulation is the most invasive out of the lot of treatment options that you have. But in saying that, out of all brain surgeries, it's probably on the smaller spectrum. So I describe it like this. So all brain surgeries are serious. It's a big deal, but in the context of all the brain surgeries that's out there, it's on the smaller end of the spectrum. So a neurosurgeon can probably get through 2 cases in a day. So it's not, so to them, it's relatively a small procedure. But I don't want to make it downplay the severity of this procedure as well. Now, DBS is not a cure for your Parkinson's. Currently, we don't have a cure for Parkinson's, but DBS is a form of method to manage your symptoms, okay? And how it works is we insert 2 electrodes into the top of your brain, and it connects to a pacemaker it sits on the top of your chest. So it's usually the brand that makes the DBS is the same brand that makes the heart pacemakers. So it's very, very similar in that regards. And if you're going through an airport or anything like that, it's just basically explaining to people that you've got a pacemaker in, and people tend to understand that a lot easier than telling someone that you've got deep brain stimulator in your brain or something like that. So the only thing with deep brain stimulation is it can only get you as best as what your medications can get you. So your best state that your medicine can get you, DBS can get you at that level and prolong it, but it doesn't get you any better than that. So now a lot of people ask me, am I too old for DBS? So the magic number we have to tell people is 70 years old. But if someone is a really fit 72-year-old versus a very unfit 68-year-old, the surgeon is more likely to proceed with someone who's a really fit 72-year-old. So it really depends on your general health as well. So I always tell people age is but a number, but you need to go through an assessment with the neurosurgeon to determine how suitable you are for surgery itself. The other thing is, if you're a smoker, the surgeons will probably get you to stop smoking and quit smoking before we proceed with any of the workup. The reason because with smoking, obviously it affects the wound healing and the post-surgical complications that come about it. So that's why they're really keen for you to quit smoking prior to coming into the workup process. Now, another myth that we need to bust is that people always say, oh, does it last? They usually come to me and say, oh, I heard that it only lasts for 5 years and it stops working. So DBS doesn't stop working, but as your disease progresses, the adjustments is slightly harder, and there's different symptoms that will come about as your Parkinson's evolve. So in saying that, if you have a really good specialist that knows how to adjust medications and deep brain stimulation, then your symptoms are going to be better managed in terms of adjusting. So it doesn't stop working. It's just about how well the person or your specialist is at titrating it. So the next question that I often get asked is, people are somewhat reluctant to explore DBS because they're worried that it'll cost a lot of money. And they'll have to remortgage their house or whatever. So there are in New South Wales some publicly funded DBS services. There are DBS services that are that have no gap under private health insurance. So you still go through your private health insurance, but there's no gap to pay in to a degree where you don't need to you don't have a significant out-of-pocket gap. Some DBS services in New South Wales do charge an out-of-pocket gap. So it's important when you speak to your specialist about exploring DBS, what the out-of-pocket cost is prior to heavily committing yourself to the workup process. So you have to explore what options you've got in terms of what you can afford and which pathway you go down. So there are pathways where you can go down where it won't be financially sort of challenging for a lot of people. So a lot of people ask me, am I a good candidate for DBS? I think another clarification we need to sort of clear up is that it's not whether you are a good candidate for DBS, but is DBS a suitable therapy for your collection of Parkinson's symptoms? So that's why often when I do these sessions, I weigh up a person's collection of symptoms first and sort of give them advice about whether DBS would be suitable. So you have to weigh up whether your Parkinson's is appropriate for DBS. So not whether you're a good candidate or not. So some of the things that is important when you're exploring DBS is you have to ask yourself, how accurate is your diagnosis for Parkinson's disease? So there are lots of conditions out there that look like Parkinson's, but it might not be Parkinson's disease. So you have to be really sure that your diagnosis is accurate. Now, the couple of reasons we do that is because some conditions are not appropriate for DBS, and some conditions that aren't Parkinson's disease but look like Parkinson's disease may also be appropriate for DBS. But what it means is that the different target site is targeted when they're doing the probing. So say, for example, if someone had something called essential tremor rather than Parkinson's disease, the area of the brain that the surgeon targets would be different compared to someone who is having who has Parkinson's disease and having DBS for Parkinson's disease. So you have to be really sure that your diagnosis is correct. So, and it doesn't hurt to get a second opinion about your condition as well. The second thing is you need to have a good response to your levodopa. So your Cinemet, queations, or levodopa, or Matterpar, or Stalevo. You have to ask yourself, do you have a good response? Do you feel significantly better after swallowing your tablet? So usually there's a rating scale that we use called Unified Parkinson's Disease Rating Scale. And usually it's done by a nurse because it takes a bit of time to do. And what we look for is about more than 30% improvement in that score. So that'll be part of your, a lot of times it's part of your pre-surgical assessment so that people can know for sure that DBS would be appropriate for you. Now, good cognition. Cognition is just a fancy word for your thinking and memory testing. So they will probably test your thinking and memory to make sure you're in a good state before they put you through DBS. And neuropsychiatrically stable is just a fancy word for you being psychiatrically stable. So do you have any hallucinations or delusions or impulse control disorders where you're reckless with your behavior, such as gambling or hypersexual behavior? These need to be stable before we proceed with DBS. So just because you have these, it doesn't mean that you can't go ahead with it, but it may mean that there might be some tweaking of your medications that might be needed and stabilized before we go ahead with it. Now, there's also something called mood stability. So anything with depression or anxiety or suicidal ideations need to be checked prior to having your deep brain stimulation surgery. So a lot of times your workup will involve seeing a psychiatrist. So don't be alarmed if you get referred to a psychiatrist in the workup process. It's usually just standard of care that we would be doing things like that. If your balance is good and your speech is good, then the likelihood of DBS working out for you is high. Now, DBS is particularly good for certain symptoms. So any symptoms that improve with your DBS is a good symptom. With your medications is a good symptom for DBS. So tremors, for example, that respond to Parkinson's medications will most likely improve with DBS. But there are some tremors that don't improve with medications that will also improve with DBS. So tremors is the only exception to the rule. So if your tremors aren't responsive to medications, there might still be a chance that it might work with DBS. With dyskinesias and stiffness and dystonia, which is the cramping sensations, these are symptoms that will most likely improve with DBS. Now, things that DBS might make worse is your talking. So if you predominantly got a really soft voice, it might mean that you may need to go for speech therapy before and after your DBS because DBS might make your voice worse. So you have to weigh up your options as to whether if we can fix most of your other symptoms like your tremors and your rigidity, but make your speech worse, is that going to be something that you would weigh up as a benefit and risk scale? Backward falling, people who are prone to falling backwards, when you have DBS, it might make it worse. So you have to be mindful that you have to have good balance prior to having DBS. If this symptom is already present, then the likelihood is that we might be a little bit more cautious in recommending DBS in your situation. Now, some types of freezing of gait. So some people who have freezing of gait, which means like they have stuttering steps when they walk. If the freezing of gait is responsive to medications like your levodopa, that's good because DBS may work for it. But sometimes medications can make freezing of gait worse. So in those situations, then DBS would not be recommended. So that's why it's important to differentiate what kind of freezing of gait you have. And that would be probably done in a setting where you get assessed pre and post medications. And thinking and memory testing is quite a strong part of the DBS workup. So cognition testing involves someone like a neuropsychologist. So if you get a little bit confused about, you're seeing a psychiatrist and then you're seeing a neuropsychologist, these two people do different things. So a psychiatrist would look after your mood such as your depression, anxiety, but the neuropsychologist is there to assess your thinking and memory capacity, because deep brain stimulation can make it worse if you're already prone to having some thinking and memory difficulties. Now, the next question to ask yourself is your lifestyle choices. Is it worth it for you? And do you need a second opinion? One of my patients who was a javelin thrower, I had to go through these options with them. We identified that, pump therapy such as the apomorphine pump or the dual dopa pump just wasn't going to work out for someone who's trying to throw a javelin. So, but he was quite reluctant for having brain surgery as well. So in that context, he had to weigh up his options about how much javelin meant for him with his lifestyle. And in that situation, that was a decision that I can't make for him, but he needed to weigh up his benefits and risks in terms of his lifestyle choices. So you have to work out what your lifestyle choices are, and what's important to you in life, and then is it worth it to go through something that is high risk as well. Always be open to a second opinion. Just because you have a really good neurologist who you've seen for many, many years and they know your history quite well, there's no harm in asking for a second opinion as well and seeing someone else. Most of the time, the neurologist that's around can, the wait list is at least 6 to 8 months before you can get in to see anyone. So it doesn't hurt to start lining up just for a second opinion and see what someone else's opinion of your condition is as well.